hopefully here for the shoulder course, right? All right. So my name is Keely. I'm a physical therapist. I actually work inside of the Heights here, literally right next door. And we'll talk a little bit more about me. But today you're here hopefully to learn about the shoulder. And I think this is a good workshop if you already have shoulder pain and you want to learn about it, kind of what you can do to kind of keep yourself healthy or improve your pain so you can keep playing your sports. And then if you previously had shoulder injuries or pain, I think it's also helpful, so you don't want the pain to return, obviously. And then maybe your friend or spouse or someone you know had a shoulder injury and they weren't able to play or do their activities, and you just don't want to go down that road. So I think everyone will get something out of this. So today we're going to go over, oh, by the way, I can turn off the lights so you can see this better, but then it's a little dark in here because we don't have any windows or anything, or I can do this. Do you want me to try both? Or what do you guys think? Yeah, I tried it and it's like, I don't know, if your eyes adjust.
I can go either way. What do you guys think?
Lights off or lights on?
I vote for lights on.
Okay, all right. And I'm going to send you guys, I'll send you guys all these slides so you don't have to if you can't quite see it and you want something, you can certainly write stuff down, but I'll actually send them out to you. So we're going to go over Shoulder Anatomy 101. So I'm going to explain kind of what normal shoulder biomechanics are. And then I'm going to talk over different pathology and pathomechanics related to different shoulder injuries, risk factors for developing those, and then some strategies to prevent or treat shoulder pain. Hopefully we can prevent shoulder injuries. That is absolutely the best way to treat a shoulder injury, is prevent it in the first place. So much easier. But like I said, hopefully learn some ways you can help manage it. And then also understand, when should I seek a professional and when can I just manage this on my own? But if you guys are already dealing with shoulder pain, I just wanted to tell you that this today is not physical therapy, okay? This is not actual medical advice. So medical advice is when I've looked at you and I've looked at your shoulder and heard your history and done your exam and prescribed things for you based on that. So this information is still very valuable, but it's more general information. So it's not a complete solution for someone who's already dealing with pain and stiffness. That needs to be directed by someone qualified. I'm qualified to teach these things, however. So I originally went to school to be a certified athletic trainer, and I got certified in that while I was in physical therapy school. So I worked as an athletic trainer kind of on the side. I am a physical therapist for over 20 years. I also did some extra training, which is not required of physical therapists. So I did a sports medicine residency in 2006, 2007. And so basically I spent a year with all of the best sports medicine individuals in the Twin Cities studying with them. I then became a board certified sports clinical specialist. And like I said, I am a pickleball player and I'm learning padel and squash, but I can't call myself a player yet. So today I ask that you don't mention your personal health information just for privacy information, but also I am recording this. Like I said, this will go up online. But if you have any questions specific to an injury or pain that you're dealing with and you want to ask me those, you can text me. You can set up a time to talk or stay after or something like that. Okay, so common shoulder pathology. So shoulder pain is the number 3 reason that people go see their doctor for pain. Number 1 being low back pain. Number 2, I believe, is neck pain. And then number 3 is shoulder. So today we're going to go over a bunch of different diagnoses: rotator cuff tears, tendonitis and impingement, labral tears and instability or dislocations, frozen shoulder or adhesive capsulitis, and arthritis. So kind of the gamut of injuries we get when we're younger and then injuries we get when we're older. So there's kind of a variety for everyone. So I'm going to talk a little bit about the anatomy now. So I kind of geek out on this stuff. So you can let me know if I'm getting over your head or you want more clarification, or otherwise I'll keep going. So the shoulder itself is made up of three bones, excuse me. So you have your shoulder blade here, you have your collarbone here, and you have your arm bone here. So those 3 bones come together to create 4 different joints in the shoulder. So the 4 joints are the ball and socket here, which is called the glenohumeral joint. You have your AC joint, which is right here. So the AC joint, if you hear people say, I separated my shoulder, that is your AC joint. So it's commonly injured like in a sprain with hockey, checking, football tackling, wrestling, that type of thing. But as we get older, we get a lot of arthritis in that joint, especially if we've played a lot of overhead sports. There's the SC joint, so right here on us, that's where our collarbone connects to our sternum. That is the only place that our entire arm connects to our skeleton, is that one little joint there. Luckily, it's a very sturdy joint. We don't get too many injuries with that. And then finally it's called the scapulothoracic joint. This is kind of a false joint. It's where our shoulder blade sits on top of our rib cage. So we call that a joint, even though it's not really kind of bone touching bone there. Okay, questions on that part? Good. Okay, so now we're going to talk about other parts of the shoulder. So let me go back one slide here. So you see the shoulder is a big like ball in a little socket, okay? So think of it as a big golf ball and it's sitting sideways on a little golf tee. So if I had a big golf ball and I sat it sideways on a golf tee, it's going to fall off, right? And so you need something to hold the ball on the socket in order for your shoulder to work properly. So the shoulder itself is a very unstable joint because we need to be able to move our arm around in all these different directions. If you think about other joints in the body, you know, there's not too much that they do. They kind of move in one plane. Our hip is also a ball and socket, but you can see it can't move half as much as the arm, which is why you hear a lot about shoulder dislocations and you don't hear a lot about hip dislocations. Not that they can't dislocate, they certainly can, but a hip is going to be more like a ball sitting inside of a socket, and the shoulder is that golf ball sitting sideways on the golf tee. So because the bones don't give us very much stability, we have to get the stability in the shoulder somewhere else. So the labrum and the ligaments are one area where we get a little bit of stability. So if you look at this picture here, this little teardrop shaped thing here, this is the socket. So all we've done is we take the ball and socket and we're looking at the socket head on. So if you look here, there's this little rim around called the labrum. So the labrum is this rim that goes all the way around the socket, and it creates like a little bit of a bumper, and it kind of keeps that ball centered in the socket, right? But it's still a little golf tee with just a tiny little rim around it. So it gives us a little bit of stability, not a ton. So we also have stability that we get from ligaments. So in this one, you can see connecting the bone to the bone, there's a bunch of ligaments there. All the ligaments combined are called the joint capsule. They kind of do a 360 around the ball and socket. So the ligaments in the shoulder, however, are very loose because I need to be able to do all of these things. So if I had very tight ligaments, I'd have a very stable shoulder, but I wouldn't be able to do very much. So the only place that our ligaments really help us out is to prevent dislocation. So when my arm gets stretched to its maximum, that's when the ligaments are going to help hold the ball in the socket. Okay, so the ligaments are very loose. They don't give us a lot of stability. The labrum is just a tiny little bumper, doesn't give us a ton of stability, so we have to get it somewhere else. And this is why the shoulder is different than most other joints in the body, where most of our stability actually comes from the muscles in the shoulder. So these are pictured here as the rotator cuff muscles. So a lot of you have probably heard of the rotator cuff, but don't know maybe too much about it. So the rotator cuff is actually 4 separate muscles. There's one on the top of the shoulder here. There's a big one on the back of the shoulder here, a little guy kind of on the side. And this is the front, that's the back of a right shoulder. This is the front of a right shoulder with the whole rib cage and everything missing. And there's a muscle on the front there. So what they do is they grab the ball from all different angles and pull the ball into the socket. So the primary job of those 4 muscles, so supraspinatus, infraspinatus, teres minor, subscapularis, the fancy names for the rotator cuff. The main job of the rotator cuff is to keep the ball centered in the socket. Does it rotate your shoulder? Yes, it rotates your shoulder as well. That's why they call it the rotator cuff. So they do move your arm in different directions, but the main thing it's doing is keeping the ball centered in the socket. But there's more than just 4 muscles in the shoulder. There's actually 17 muscles that connect to the shoulder blade. I won't go through all of those. But the reason I bring that up is because the shoulder is very complex. We talked about there's only one spot that the entire arm is connected to the skeleton, and the rest is all muscle. So if you have a dysfunction in how your muscles are working, you will have some problems, okay? So we're gonna talk a little bit now of physics. We're almost getting ready to talk about the actual injuries, but this stuff is important because I bring this stuff up when we talk about why we get injuries. So this is something called force coupling. I'm actually gonna draw some stuff for you if you don't mind, because I think the pictures are only slightly helpful. All right, so we have, I'm a horrible drawer here. So this is your shoulder blade, okay? The socket and the ball here. Can you kind of see that? All right, so we said we have 4 rotator cuff muscles that hold that ball into the socket, right? Well, there's also a very big muscle out here called your deltoid. So the deltoid, if you look at like kind of big basketball players with those big round shoulders, that's the deltoid. So I have only seen 1 deltoid injury in over 20 years of working in physical therapy, and shoulder is my specialty. So that's primarily what I've seen over the years. So, so 1 deltoid injury, and I guarantee I see rotator cuff all day long, right? So the rotator cuff is the weak link. They're smaller muscles. They sit in different spots. They're more likely to be injured because of where they're located. So in order for the shoulder to function properly, these 4 muscles have to add up in strength to equal that big muscle, okay? If they add up in strength, which is what most of us, being able to reach our arms around can do, is it holds the ball in the socket, the rotator cuff, and then the deltoid is able to raise our arm up and down because the rotator cuff is opposing it, okay? Now, if you have a scenario where you have, can you see that behind my thing? Probably not. So it's the same scenario. You still have your rotator cuff, but let's say we tore that one, okay? And let's just pretend these other 3 are still working, but our deltoid, which is never really injured, is doing great. So now when I add up those 4 muscles, they do not equal this. So this one is now gonna overpower those 4, and what happens is the shoulder goes up. So now I'm going to give you an extreme example. So if someone had no rotator cuff, so someone fell in the parking lot and tore it all off. I've seen people who have no rotator cuff. Basically what happens is this is how they raise their arm. Okay, the shoulder goes way up, but their arm does not. Okay. Now, most people that I see are not that extreme. I see the majority of people I see are somewhere in between. And so if you have 1 rotator cuff is torn or partially torn or just weak, and the other 3 are working well, you can somewhat keep that ball centered in the socket. If you've got 2 or more that are significantly injured, that's when it becomes much harder to reach your arm over your head. So some people with torn rotator cuffs that can't be repaired, they will never reach their arm over their head. So this is important because of, as you can hear, rotator cuff problems. But there's also another force. So this is called a force couple, okay? So we're making sure we have enough force on one side to keep the motion where it's supposed to be. The second force couple that we have in the shoulder, so here's my shoulder blade, this is my head, got another shoulder blade over here, there's my spine. Okay, sorry, I'm not a good drawer. So you have a muscle that goes up this direction. This is our big guy right here that a lot of people have tension in. So that's called the upper trap, okay? So that muscle is rarely not working well, okay? It's actually usually working a little too well. And then we have some weaker ones down here called the lower trap. And then you have one underneath the shoulder blade here called the serratus. Okay, so I don't know if I drew that very well, but you want equal pull on each of those so that when I raise my arm over my head, my shoulder blade spins in place instead of going in the wrong direction. If I have way too much of this guy and not enough of these guys, my whole shoulder will shrug up as well. And it changes what happens underneath the shoulder blade, which is where our rotator cuff is. Okay, so this is the second force couple. So that's what's in that, but I didn't think it was very clear. So, okay, so now we're ready to move on to actual injuries. So our first injury group we're going to talk about is impingement syndrome, which I'll explain what that is, rotator cuff tears, tendonitis, and bursitis. So impingement syndrome is actually a generic term. What all it means is that you have pain in a certain location. Doesn't tell us what your injury is, it just tells us you have pain and where they think the pain is located. So if you look here, that was, so here's your collarbone, okay, and here's the ball part, here's the socket. It's just kind of hidden with some of the muscles in there. So underneath this bone, which is part of our shoulder blade, and above this bone, which is the ball part of the ball and socket, is where our rotator cuff lives. It's a small space called the subacromial space. So if you have a problem with a rotator cuff tendon, like a tendonitis, there's also something called a bursa in there. Bursa is like a fluid-filled sac, and it's trying to prevent friction, right? But bursas can become inflamed, and then you get something called bursitis. So bursitis, rotator cuff tendonitis. You also have a bicep tendon, which runs right up in this area too. So all of those things are underneath that area we're talking about. So when a doctor gives someone a diagnosis of impingement syndrome, just means that that's where their pain is, and they could have any number of those problems or a combination of them. So tendonitis, bursitis, and even small rotator cuff tears. Usually, but not always, this stuff comes on with kind of gradual onset. I maybe did too much over the weekend, or I don't even know what caused my pain. There's not usually I fell and now my shoulder hurts. It's usually kind of gradual. But 80% of the time we can get this better with just physical therapy or physical therapy and an injection. So impingement syndrome is for generally people in their 40s to 50s. The main complaint is pain when they're lifting their arm up, such as reaching forward, especially if they have something with a little weight in their hand. So kind of picture taking something out of the cupboard with a little bit of weight. There's an arc of pain that's very common, which is kind of right in this range here, or kind of out in this range here. They also have pain or stiffness with reaching behind the back or reaching into the back seat of the car, and pain lying on the side. So things that make this feel better is basically anytime their elbows are at their side. So if they're lifting the same weight that killed them out here, it feels just fine as long as their elbow's at their side. So what causes impingement syndrome if there's not usually a significant injury or mechanism? So abnormal shoulder mechanics, which is the stuff we were talking about with the force coupling, and tightness in the shoulder, which we're going to do a test here in a second. Genetics. So there's in the shoulder, we have that ball and socket, but there's this little area is like a roof over it, okay? Some people have a roof that's like this, so there's lots of space. They never have shoulder problems. Some people have one like this. They can develop shoulder problems, and the ones that are like this will pretty much always develop shoulder problems. So there's some genetic components to this. And then it's what you've done with your shoulder throughout your lifetime. So Adam here, the GM, is probably hit 8 million backhands in his lifetime, right? So it does, it takes a toll. So what you do matters. So we're gonna do a little test. Everyone's gonna do a quick little test on their shoulder. I'm gonna have you stand up for just a second. You're gonna put your thumb up the middle of your back as high as it can go. Kind of make a mental note. How high is that? How tight does it feel? And so on. And now you're gonna do the same thing with your dominant arm. Okay, how many of you, I see the look on your face, how many of you notice that there's a significant difference? So we got 3 and we got 2, like, nah, doesn't seem too bad. So that is like a super quick test. That's a test I often run at events to see if you're at risk of developing shoulder and elbow. You go ahead and have it. So why does that matter? So first of all, that tightness is common in impingement syndrome and sometimes some labral issues and arthritis, frozen shoulder. Like there's many different causes for that being tight or different diagnoses that that's tight with. So they did some research because it's so common. They said, what happens when that part of the shoulder is tight, right? When that part of the shoulder is tight, remember we have the ball and socket. Let's pretend this is the front, this is the back. It pushes the ball up and forward in the socket at all times. So no matter what you are doing, whether you're using a mouse or hitting an overhead or crocheting, your ball is sitting up and forward in the socket, right? Well, what is up and forward in the socket? The rotator cuff, the bicep, the labrum, the bursa, all of those things are up and forward in the socket. So if you haven't developed pain yet, it may be coming your way. I'll teach you a really quick exercise that hopefully will kind of, stop that process or at least help it go in the opposite direction. So you can do this sitting or standing, but you're going to put that same tight arm behind your back. So, yep, and then standing is ideally better, but sitting is fine. And then you're going to stand up or chest up as high as you can. Okay, do you feel a mild little stretch in your shoulder? Should not be sharp, intense pain. Mostly you'll feel it kind of in the front of the shoulder. Mm-hmm. So you can do this 1 minute here and there throughout the day. I particularly like people do it after they're done playing. Okay, so, or in the hot shower, when your body is warm, that's the best time to do it. But the other reason you do it after you're done playing is research shows that we tighten up when we do overhead activities, which maybe you're hopefully not having someone lob you 800 times, but I was like, there's got to be a lobber in the group. So that would be a stretch that you can do to try to keep that from being too tight. And have a seat again. So most of the research on a lot of these shoulder injuries in sports is done on baseball players, some on tennis, and less on other sports. Certainly there's nothing on pickleball and padel per se. You can look in the last couple of years and start to find some research on that. Squash has some, but it's mostly done in baseball and tennis. And so with baseball, they found that Major League Baseball pitchers, they measured how tight their shoulders were before they pitched, after they pitched, and then successively every single day for, a week or so. And what they found was every single one of them lost motion behind their back. They all gained most of it back by the time they were ready to pitch again, which is 5 days or whatever they're at. The difference is the people who end up having tightness that lasts is, so if my shoulder tightens up and then I gain most of it back, and then I play again and it tightens up and I gain most of that back, and then I play again, right? And so it's either the repetition that we're playing or it's just our body doesn't tend to loosen up.
So for sports with this, what about volleyball?
Same thing. Yep, absolutely. Anything overhead.
Okay.
Because what it is it's you're making contact with the ball, and then it's the slowing down of your arm that the back of the muscles, the back side of the shoulder is controlling. That's what makes them tight. Even like follow throughs on, you don't have to necessarily do overheads, but like if you're hitting a forehand and you have to follow that through, that whole follow through period, those muscles are working really hard to slow your arm down. Like a baseball pitch, your arm is going 7,000 degrees per second, right? And so maybe my overhead in pickleball is not quite going 7,000 degrees per second, but it's a very extreme force on the shoulder, and those muscles have to deal with it. So I always suggest, if you do have any tightness, is that every single time when I'm done playing, I'm just going to do that for like a minute or so. And believe me, there's a lot more stretches you can do, but that would be a good one to start with. Okay, so rotator cuff tear. So first of all, impingement syndrome that we were talking about, that kind of generic term, it is a precursor to rotator cuff tears. So rotator cuff tears Not that they can't happen in their 30s and their 40s, but they're more prevalent in your 50s and 60s, and each decade you have more likelihood of having a rotator cuff tear. Rotator cuff tears do tend to get larger over time. However, not all rotator cuff tears need to be surgically repaired. So a lot of people will get their MRIs and they go, oh, I got a tear in there, I bet I need surgery. My preference is you have a shoulder surgeon look at that MRI and examine you and determine if you need surgery. The reason I say shoulder surgeon is, in general, I find that general orthopedic surgeons will say, yep, I can fix that, which they maybe can fix that, but is it necessary and is it in your best interest? Where a shoulder doctor goes, nah, based on your age and your activity and the type of tear and the location and the natural history of this tear, I think we can just kind of monitor this and see how you do. Let's do, physical therapy or whatnot. So that's where I'm biased with that, but I would always have an orthopedic surgeon that is specialized in that body part look at it and make a decision. They're not usually ones that push people to have surgery if they feel like you can benefit without. Why do you want to avoid a rotator cuff repair? It is one of the longest recoveries we have. It usually takes between 1 to 2 years, and I promise you it's not going to be as great at 2 years as a normal shoulder. If you're really young and it was more of a traumatic injury to your rotator cuff, you did fall off a horse and tear your rotator cuff, you have a much more likelihood of having a really good outcome. But most of these rotator cuff tears are degenerative, and they've come on over years of your activities, years of your genetics, years of your mechanics of your shoulders slowly kind of going in that wrong direction. I don't know how long my arm's been tight behind my back, so those things all add up. And so the tissues tend to be not as good of quality, right? Also, when I'm 20 and I have surgery, my muscles look different than when I'm 60 and I have surgery. So rotator cuff repair is something I hope to never have done. I've already had one shoulder surgery, kind of similar to the younger group where I had some labral issues when I was younger. But I try hard to not get a rotator cuff tear so I don't have to have surgery. So how do you prevent impingement syndrome and rotator cuff tears? Avoid lifting over your shoulder height. So this is hard for people who really like to lift weights. Military press, overhead press, anything you're pressing weight, or incline press, anything you're lifting weights over your head. Me personally, being that I've already had a shoulder surgery, I will never do those exercises. Me being someone who treats rotator cuff tears and surgeries all day, I will never do those things. What you do with yourself is your own choice, but I would never do that, because remember how we talked about how the ball kind of shifts a little bit upward if we have any rotator cuff injuries? That's happening with arm weight, just the weight of my arm. So this is what someone who has maybe some weakness or a partial tear of the rotator cuff, their ball will come up I'm trying to make it look not too obvious, but it'll come up some. That's with the weight of my arm. So now I take even a water bottle or a 5 or a 10 pound weight or whatever weights people are adding. That would be something that it's going to increase that shearing force of the ball even more. Lifting heavy objects with the elbows away from the sides. If you've ever had, carrying something down here, a big pail of water down here, that's not too bad, but you hold it out even 2 inches, that's tough. I'm not going to walk like this back, right? So anytime we have the elbows away from the sides, the force on the rotator cuff goes up exponentially. Also avoiding repetitive overhead use. We naturally have less space for our rotator cuff when our arm is over our head. So it's not like I never will paint and cut in the edge of my room, but that's not going to be my job, right? So luckily I don't have to do that. Maintaining those good shoulder mechanics. So if something is off, you have pain, go in and get that tuned up early. It's so much easier to just learn a couple things to do versus like when it's full-blown significant injury. So now we're going to talk about labral tears and instability. Any questions on the rotator cuff and impingement yet? Okay, so labral tears and instability. Remember that labrum is the small rim around the socket of the shoulder. So right here, okay? So its job again is to make that socket a little bit deeper, keep the ball centered. There's the bicep tendon. So our bicep starts way down here and then comes up and splits into two. One of our bicep tendons runs up right through that same area where the rotator cuff is, but then it connects all the way onto the shoulder blade at the labrum. So it connects to the labrum. So there's a common type of labral tear called a slap lesion. It's called superior labrum anterior to posterior slap. All that means is the very top of the labrum is torn from the front to the back, okay? And it's very common in overhead sports and younger athletes. If we did an MRI of everyone who is 60 who had played any overhead sports, a good majority will have slap tears. So these can kind of just come on from overhead use. Sometimes they become problematic. The labrum will also tear if you dislocate your shoulder. So if my entire ball comes out of the socket, I'm going to hit stuff on the way out, and that's where the labrum is. So it'll actually tear the labrum on the way out. So what causes those slap tears? So slap tears, again, that's where the top of the labrum is torn, where the bicep connects to it. This is when I'm doing overhead activities or things where I have this long force on my arm, and then there's a pull on my bicep to control that motion. And so the bicep constantly pulling on that, especially through high physical activities, will keep pulling on that labrum, and eventually sometimes it can tear. Abnormal positioning of the ball in the socket. So remember, if you have those tight ligaments, it pushes the ball up and forward in the socket. So up is the labrum, so you're going to be bumping into that bumper all the time, and so that can tear the labrum as well. So this is kind of an example of, here's your ball, here's your socket, and this is where that slap tear is, where the bicep is kind of pulling away with that labrum attached. So what causes shoulder dislocations? Age is the biggest factor. So in general, a 16-year-old versus an 80-year-old who's going to be more flexible, right? And then a 16-year-old, how much exposure are they going to have to sports and things like that? A lot. They're playing a lot of sports. 80 years old, probably not playing too much. And the 16-year-old is going to have much more risky behavior as well, right? So age will definitely put you at risk for shoulder dislocations. Your activity. So if you're wrestling, football, hockey, stuff like that, where you're getting collision sports, you're more likely to dislocate it. There's something called a generalized laxity, where you have really loosey-goosey tissues. Some people, their elbows hyperextend and their knees hyperextend, and they can put their hands on the floor. Not like me, where I can only get halfway. So those people who are very loosey-goosey have a higher likelihood of dislocating as well. If your rotator cuff isn't functioning properly, an extreme example would be someone who had a stroke and their rotator cuff doesn't work and they're constantly dislocating their shoulder. There's no force put on it. It just can't hold it in place anymore. And certainly if you've had previous dislocations or subluxation. Subluxation is it went out, came back in on its own. No one had to do it for you. Dislocation is it's out and someone had to put it back in. So remember, when you dislocate or sublux, you're going to tear that labrum, you're going to tear the joint capsule of the ligaments, and then possibly you're going to give yourself a bony deformity. So you got your socket, right? If I hit that on the way out, I can chip the socket. So now I've got a golf tee with a chip in it. If anyone's tried to put a golf ball in a golf tee with a chip in it, it keeps falling off, right? So people who have bony deformities typically need surgery. Yeah, so that where the bone is chipped off. So those are the ones who they sign up for surgery right away. So the first time you dislocate, a lot of times they don't just sign you up for surgery. They just see, how are we going to be able to manage this, and does it keep coming out? So how do you prevent labral tears and dislocations? Get older, right? So that's the one good thing we have with getting older. We get stiffer. We don't play quite as many sports. We don't take as many risks. So when I have adults that dislocate their shoulder, I'm not super concerned about it happening again. In fact, I'm worried they're going to get very tight after their injury. So when we're young, yeah, we have to kind of try to be careful. So strengthening the rotator cuff will keep that ball centered in the socket. By the way, when we strengthen the rotator cuff, it's very lightweight and very high repetition. So you're doing like 40 to 50 repetitions with an exercise, and the weight is like your arm weight or a tuna can or something like this. It's not, oh, it's light, I'm only doing 5 or 10 pounds. What happens is you have big muscle groups like the deltoid and the traps and such. We already talked about this muscle tends to be really strong. So if we're kicking in a lot more of that muscle, it's not really helpful for your shoulder function. If I strengthen the deltoid, which we already said is always strong and always never injured. So if I'm strengthening those because I have a heavier weight, I'm not really helping the function of my shoulder. And if you develop tightness behind your back, learn those stretches and kind of get that taken care of. Any questions on that stuff? So frozen shoulder adhesive capsulitis. So this is, you get pain and inflammation, and then there's something called relative immobilization. This could be, I had shoulder surgery and the doctor put me in a sling. That's immobilization. But what if I strained my shoulder and it hurt, so I didn't use it as much as normal? That's also relative immobilization. And what happens in some people, and this has to do with them particularly, it's not like anyone who injures their shoulder or anyone who has shoulder surgery will develop frozen shoulder. It's something about their genetics and how they heal to develop this. So what happens is your body starts laying down way too much scar tissue. And because you're not moving it, you're not stretching that out, this adhesions form. And the symptoms are this persistent pain, especially with movement and at night. The stiffness, you get a gradual loss of motion, making it hard to perform daily activities like reaching, lifting, and significant difficulty reaching behind your back. You do not want frozen shoulder, but like I said, you can't really prevent frozen shoulder. There's not a prevention of this. Frozen shoulder takes a really long time to fully develop, but it takes a really long time to go away. The good news is it typically will go away. So there's 3 phases. The freezing phase, at the beginning, it's just painful. I can move my arm around, but it's just painful, right? Just like I injured my shoulder. What ends up happening is those people start noticing, boy, now my shoulder seems like it's getting stiffer. Now I can't sleep at night. This pain is now becoming constant, right? So this is a miserable kind of condition. So the freezing phase goes from 2 to 9 months. The frozen phase, 4 to 12 months. And the thawing phase, which is when the pain is starting to go away, but I'm still stiff. And the stiffness is starting to go away, up to 24 months. So when people develop frozen shoulder, they have kind of a long road ahead of them. And so who develops frozen shoulder? Those between 40 and 60 years of age. Women are 4 times more likely to develop. And like I said, if there's some type of injury or reduced mobility, not always, though, there's something called idiopathic frozen shoulder, which is we don't really know the cause. Most people that come in and see me don't really have a specific cause that they, I know I did this. But shoulder injury or a minor thing that they did, I did too much of this weekend. And then recovering from surgery certainly puts you at higher risk just because of the significant immobilization and the significant injury. And then people who have certain diseases are much more likely to develop frozen shoulder. So if you have diabetes, over or underactive thyroid, and cardiovascular disease. So first thing I ask almost every shoulder patient I have is, do you have diabetes or a thyroid problem? Because then it keeps it in the back of my mind that their shoulder injury might not just be a shoulder injury, it might also be developing frozen shoulder. So the treatment takes between 1 to 2 years, right? Because that's how long these things last. And in physical therapy, what I'm doing is I provide them specific stretches for where they're tight, educate them. Is it okay to push through pain? Is it not okay to push through pain? And then there's different techniques we do with our hands, and there's something called dry needling where we can loosen up the muscles, which also get tight. They often will do corticosteroid injections into the joint space. So this is they're doing ultrasound or x-ray to make sure they get it in the ball and socket. And rarely do people need surgery. I probably see 1 or 2 people a year that need surgery on this. And most people, that's just going to kind of get better with those other treatment methods. It's a little, like I said, it's a little bit miserable, but it does eventually go away. Okay, and finally, we're going to talk about arthritis. So there's a couple different types of arthritis. I'm going to talk about a few of them. One is osteoarthritis. So this is general wear and tear. So when someone says I have arthritis, they're probably saying they have osteoarthritis. You can get psoriatic arthritis and rheumatoid arthritis. So there's different types, but most of the time our wear and tear stuff is just the osteoarthritis. Primary and secondary means was there an injury or not an injury. So if I dislocated my shoulder a bunch when I was younger, that's secondary osteoarthritis. It's from the trauma that occurred at my shoulder. So if I had an ACL tear when I was younger, when I get older, I have secondary osteoarthritis. Primary osteoarthritis is, I don't know, it just kind of gradually got worse as I got older, right? Now you can see, I brought a normal shoulder x-ray. This ball is nice and round. It looks like a light bulb. It's smooth. The socket looks like a nice little golf tee, right? This looks good. There's also, it's a little hard to see, but the bottom of this bone is far away from the top of this bone, okay? And there's one other thing we look at with x-rays. This line here should in general make an arch with this line here, kind of like St. Louis arch there, okay? So that's a normal shoulder x-ray. Now here, you can see that does not look like that, right? So that smooth ball, like there's a whole bunch of bone built up down here, and the ball is flatter. So if you look at how round that is, and then you look at that one, how flat that one is. Both of these x-rays still have plenty of space between this ball and this bone up here. You can see that the amount of space in here, see that gray area, is much smaller here. So the gray space represents cartilage. So the more gray space you have there, the more cartilage you have. The more it's white next to white, that's more kind of bone on bone. And again, you can see this person has a big buildup of bone in an area that's not supposed to be. Both of these ones, the arc for the most part is still intact, okay? So that's what arthritis looks like. So causes, like I said, you can have previous trauma such as dislocations, general wear and tear, genetics unfortunately are a factor. What happens, stress on the bone causes the bone to grow. And so that's why you get those bone spurs like in the bottom here. And it wears down the cartilage, which is why we lose some of the space there. But it also can, in some spots, wear the bone down, so the bone gets flatter. So you can imagine a big round ball in a nice socket can move really well. A flatter one with this big chunk of bone down here, it's not going to move as well. So they get not only progressive pain, but they get loss of motion as well, and they get crepitation. So these people will have loud, noisy joints. Yeah, it kind of freaks a lot of people out to hear it. So there's a different type of arthritis called rotator cuff tear arthropathy. So this is arthritis in someone that is 100% because they don't have a rotator cuff. Okay, so the rotator cuff tore at some point. For whatever reason, they didn't get it repaired in time, or as soon as the doctor looked at the MRI, it was too far gone, they couldn't repair it. So this person no longer has a rotator cuff. Now, why does that matter? Why does that make them develop arthritis? So remember that when we don't have the rotator cuff, the ball is going to go up and down a lot, right? So that's going to wear that bone down, so it starts to flatten out. It's going to wear the cartilage down. The ball is going to go up in the socket. So remember this line that we were looking at here? Boop, there it is up there now, right? So it's supposed to be this smooth arc, and this one goes up way up there. This one's not quite as bad, but there's a little bit of a bump there. There's supposed to be space between this bone and this bone. This bone and this bone, they're actually contacting it. That person is wearing away that bone at the top. So the reason why we know this person doesn't have a rotator cuff without doing an MRI is the rotator cuff lives right here. Well, that bone is touching that bone. It's not there. That rotator cuff is gone. So if you have a rotator cuff, this is why we also don't want rotator cuff tears, you will go on to develop arthritis. It's just, if you have a really bad rotator cuff, you develop it much faster, okay? So we want to take care of those rotator cuffs, even if we're young. So the cause of this is rotator cuff, what we call deficiency. Deficiency is likely a significant tear where one is completely torn, if not multiple ones are completely torn. So the lack of the rotator cuff causes that shear of the ball going up and down. Remember that force couple with the deltoid being too strong. There's nothing to hold the ball down, so that ball goes higher and higher and higher. The symptoms are progressive pain, loss of motion. This type of arthritis will eventually lose the ability to reach their arm over their head because they don't have that rotator cuff. Okay, and they will also have a lot of crepitation or crunching. So the management of this, it absolutely is management, right? We're not curing arthritis. So in physical therapy, these are probably the hardest people I treat because their shoulders are just irritable and they don't tolerate much at all. So I'm trying to maintain their shoulder for a prolonged period of time because maybe they're not healthy enough to have their shoulder replaced, or they're too young to have their shoulder replaced, or a shoulder replacement would completely change their lifestyle. So that is the reason why I treat these patients, is I'm trying to prolong the time that they get to use their own natural shoulder. And so I'm trying to keep the ball as round as possible by keeping their mechanics as round as possible, their range of motion, so they can dress themselves and reach behind their back for self-cares and things like that. So we try to strengthen what rotator cuff they have left. So if you have 2 of the rotator cuff muscles are working, they'll pull in somewhat. So we want to strengthen those 2. And then I also educate a lot. Again, is it okay to push through pain? My shoulder just clunked when I did that. Should I keep doing it? And then, like, some people are, the younger ones are like, what can I do in the gym to make this better? And so I answer all those questions for people. Injections, they also do injections in these shoulders inside this joint space. So they do that under X-ray or ultrasound guidance. So these are the 2 surgical options. You have a shoulder replacement, a normal shoulder replacement, and something called a reverse shoulder replacement. So if you have normal arthritis, so wear and tear, or I dislocated it when I was younger and developed arthritis, all they're going to do is replace the ball with a new ball and the socket with a new socket. And you're going to be happy as can be. People wake up the day of surgery and their shoulder pain is gone and they're happy as can be. There's very happy people. The second surgery, this one where we make the socket into a ball and we make the ball into a socket, is for the people who have no rotator cuff. So if I took someone who had no rotator cuff and I replaced their ball with a ball and socket with a socket, they wouldn't have pain, but they couldn't use their arm. Okay, so they'd be somewhat happy. But this came around, I don't know, when I first started treating, I'd never heard of a reverse shoulder replacement. So I would say probably about 18 years ago is when I first started hearing about them. So that all it is physics has changed. Remember that deltoid muscle is really strong and hardly ever injured. So in these people, the deltoid, because it changes the physics of how the shoulder works, now the deltoid can lift the arm up. That's all it is. These people end up with short little shoulders. They look different. The bra falls off for the women all the time. They're not great. But the people who have these are very happy. However, why do you not want one of these? These have lifetime lifting restrictions, so you can't ever lift more than 10 pounds with that arm. They don't want you to do impact vibrational activities. These reverse ones, you can't push that arm behind your back to get out of a chair. It can dislocate, right? For a while, they don't let anyone reach behind their back with that one at all. So this is not a good choice for someone who is pretty active. This is for someone who's 80, who's already not doing a lot of those things, right? They're not carrying in all the groceries on their own. So we want to prevent this. And the way that we prevent this stuff as much as we can is taking care of our rotator cuff throughout our lifetime. Okay, so summarizing what you've learned today, shoulder pain is common. Shoulder pain can be caused by age, stiffness, gender, exposure to sports, genetics, all those things, but it can also be caused by those shoulder joint mechanics. So those inadequate force couples, so the rotator cuff isn't keeping the ball centered on the socket, or the shoulder blade isn't rotating properly, which takes away the space for the rotator cuff as well. Remember that tightness behind the back also changes where the ball sits in the socket at all times. It's way easier to treat these things early on, and we have much better outcomes. Like I said, you don't want to start going down that road at all. So it's much easier to get it kind of taken care of earlier on. Physical therapy helps. I educate a lot of people, kind of answer a lot of questions, give them individual exercise based on whatever their biomechanics look like. Is your shoulder blade rotating enough? Is your ball staying centered? Which rotator cuff muscle is weak? All of those kind of things. And then hands-on techniques that we do as well. And then comprehensive care for shoulder injuries is from individualized treatments, right? So you can go online and Google rotator cuff exercises and are you doing them right and are they the right ones for you and all of that kind of thing. So if you already have pain or you want individualized treatment, today for people who attend, I'm giving 50% off for a 60-minute evaluation and treatment. That includes a review of your shoulder pain and history. I do a 6-point shoulder rotation range of motion assessment. I look at your rotator cuff strength, your shoulder blade strength, your posture, your alignment, movement analysis of your shoulder mechanics. I give you a customized report of my findings and my suggested treatments, provide you with custom exercises, including videos for at home, and then depending on what we find, hands-on treatment, depending on your exam findings. But because I'm giving such a big discount, I can only do 3 of those at the discount, and you have to sign up today. So you're welcome to do that. No pressure. So next steps, I'm going to be sending out an email after today's course where I'm going to put all these slides on a little PDF for you guys. So you get all of that. And then if you're having pain, you can set something up. Any questions?
Okay, so this is the ball, the top of the humerus, correct?
Yes.
And this is the socket, like the T in golf, right?
This way.
Or this is?
The T is sideways.
Yes, T is sideways.
And the ball sits in it that way. And then you have a roof over it.
Got it.
Yes.
And if it got dislocated, it can only be treated or reversed through surgery?
No, not necessarily. So when someone dislocates their shoulder, especially when it's the first time, they typically will not do surgery because, we're going to immobilize them for a bit of time. We're going to strengthen. We're going to avoid certain movements for a while and strengthen the rotator cuff to try to keep it centered. And so the majority of people who dislocate their shoulder don't need to have surgery. Those that chip the bone off with it are much more likely to need it. Or the first time I dislocated, I was tackled, right? And then I'm just saying that would be like an injury in football. Someone, hit me and my arm dislocated, right? And then the second time, I was diving in the water and my arm dislocated. And then the third time, the door swung open and now it dislocated. And the fourth time, I sneezed and it dislocated. So these people have progressively less force to dislocate their shoulders. And if they do high-risk activities, motorcycle riding, rock climbing, things like that, they will do the surgery. The threshold for doing surgery is much lower because they have higher risk activities. If you're a sedentary desk worker and you get out and play golf a couple times a week and that's it, they're less likely to do surgery on you than someone who said, well, I hang from my arm on a cliff. And if that dislocates, or if I'm on my motorcycle and that dislocates, my life could be at risk. So they kind of take all that, and your age, right? If you're 45 and you dislocate, you're like, you're going to kind of stiffen up. You're probably not going to do high risk activities. Yeah. So, yeah.
Okay, so other than what you've mentioned, couldn't stress and anxiety also contribute to pain in your shoulders?
Absolutely it does. Absolutely it does. Absolutely it does. So we have this, we call it biopsychosocial. Mm-hmm. All injuries are a combination of physical stuff, like I talked about, right? Mm-hmm. And then psychosocial stuff. All your experiences in your life that have come up. Like I had a patient one time, his dad had a rotator cuff repair, and the physical therapist, I don't know who he was, cranking on his arm, must have been really tight, and the physical therapist thought, this is what I need to do. Tore the dad's rotator cuff. He had to end up going in and having surgery. The second repair never goes as well. You can imagine the long-term outcome was not as good. So now the son comes in for his first visit for physical therapy after he had his rotator cuff repair. And he was like a deer in headlights when I came walking up to him, because I was going to look at his incision to make sure it didn't look infected. And he's like, well, what are you going to do with your hands, right? He became very stiff after surgery and had a lot of pain after surgery. And I think part of it was his fear of what was going to happen, or the stress of, I don't want my shoulder to turn out like my dad's. And I mean, that's just one example, but absolutely. If that guy, the same guy, his dad had rotator cuff repair and he did great and he did awesome, and now he can use his shoulder without thinking, he might have had a little bit of a different outcome. So absolutely. Mm-hmm.
That's why I guess it's very important to know how to manage your stress.
Yeah, and that's a lot of times what my education does with people. Ooh, I felt that. What's that? Should I do that? Should I stop? Like it'll stress you out because you're not sure, right? When I say, oh, here's what that is. This is okay. That's a safe movement. It's okay to do that. Then next time that happens, you're not going to go, oh my God. You're going to go, oh yeah, Keely said this is okay, even though it kind of made a little click there. It's fine. I'm not hurting anything. And there's just different outcomes. So we definitely address that stuff as well, for sure.
What's the difference then between a dislocation and shoulder separation?
Different joints. Yep. So that AC joint, which is right here, is very commonly injured when we are checked or tackled just because the force is directly landing on that. And so your collarbone will actually come up and stick out. Have you done a separation? Yeah. So your collarbone will actually stick up. So typically you're going to get more of a bump there. And so there's ligaments that connect these two bones. And there's also ligaments that connect, I'm trying to take my microphone. There's the front of your shoulder blade, which doesn't seem like it's right here, but it is. So the front of your shoulder blade also has a ligament that comes up to your collarbone. And so there's degrees of separation. So you can do a minor separation, doesn't feel minor when you do it, but that would be spraining those ligaments, but not a significant rupture or tear. And then, you can do, I've torn the ligaments here, or I've torn the ligaments here and there, and then the shoulder blade the collarbone sticks up significantly, and the shoulder looks like it's kind of sunken down. So they typically manage those without surgery. Typically, if it's like way out, they'll do surgery because it's you're going to get it caught on things if it's way out like that. But most of them they manage that non-surgically, and then the dislocation I was talking about is the ball coming out of the socket. So, yeah, both of them are kind of the same thing but different joints. Yeah.
Can you talk more about it was weightlifting, overhead, on the shoulder, and then you had a comment on one of the slides of lightweight, high rep. What does lightweight mean?
Arm weight.
Arm weight?
Yeah.
So how much is my arm weight in a row?
Yeah, just whatever your arm weighs. So like a bigger person will have a heavier arm, but they'll have bigger muscles, right?
Okay.
A little person has lighter arms,
Okay.
but they have smaller muscles. So it's just your arm weight.
Okay.
So like there's different rotator cuff exercises, like deltoid raises. People love doing deltoid raises in the gym, right? Yeah. The deltoid raise, it strengthens the deltoid, but it's also a rotator cuff exercise. So I don't ever give deltoid raises to patients because once you get higher in the weight, I'm strengthening my deltoid. So there's weightlifters struggle with this, right? Bodybuilders and weightlifters really struggle. So deltoid is not something I ever choose to strengthen in a patient who already has a rotator cuff problem if the ball is coming up. If you haven't ever developed them, you're young, you can certainly kind of do it with lighter weight. So whatever weight seems light to you, that would be what I would use. But if you're talking about, I already have a shoulder problem, I already have a rotator cuff problem, I'm going to tell you your arm weight is plenty, and you're just going to do very high repetitions, 40 to 50 reps.
What about I've seen like bracing?
Yeah, so
What do you know about that?
so the benefit of bracing, it pulls you into good position. It absolutely does. And so your brain is kind of learning this is where I should be. It gives a stretch to the muscles that are tight. We all sit like this all day long, so our pecs, for instance, get very tight. And so when I'm pulled back with the strap, it'll stretch some of those muscles. So there is some benefit to it. The downfall is when I have a strap or a brace holding me in that posture, what do you think my muscles get to do? Oh, thank God. The strap is holding her shoulders back. I don't have to do anything. So I'd absolutely never recommend them long term. So if you wear it for like 20 to 30 minutes for a stretch, I think that's fine. But I would never do it long term. I would say, let's make your muscles do that instead. Yeah. And posture is a huge thing for shoulders, huge. So I don't tell people not to get them, but I tell them don't wear them very much for very long. Yeah. Any other questions? Good.
This was more educational than I've had from other physical therapists who have actually gone for treatment and stuff.
Yeah.
So I really appreciate it.
Good. like teaching. So yeah, good. And I think like it's important to understand, like I'm not just going to give you these 3 exercises and you're like, I don't feel like they're doing anything. Why am I doing this? It's really hard to follow through. But if you understand the mechanics of what's happening with my shoulder, and then what is this exercise going to do about that, I think it makes it more beneficial for people to follow through on their routine a little bit more, you know. And like my main goal today is to teach you guys like take care of your shoulders, right? Because it gets exponentially harder to live a good life when you start developing all those different things. The only thing though with that frozen shoulder that I was talking about, you can't prevent it, but if you learn about it early on and you learn the right things to do early on, it won't be as impactful or as painful to you. So you still take a really long time to recover. It's not like my patients who don't do their exercises after surgery are the ones that develop frozen shoulder, and the ones that do their exercises don't develop it. But the ones that don't do their exercises that do develop frozen shoulder have a really tough outcome. And the ones that do their exercises and develop frozen shoulder end up having less debility and less problems because of it. So yeah, so it's good to know about, but it's like if you don't develop it, then you don't have to worry about that, which is nice. So yeah. Well, I welcome any questions you guys have individually. I'm going to turn off my mic and the